Okay. Dear colleagues, thank you for your invitation to take part in the conference, and I would like to thank you for your consideration in advance. My co-author and me are allergist immunologists, and the main population of our patients are patients with allergic diseases of the respiratory tract. I hope that our observations of patients with severe asthma and concomitant nasal diseases will be interesting to you. The theme of my report is as follows: efficacy of dupilumab therapy in comorbid patients with severe bronchial asthma and chronic inflammatory nasal diseases. The single airway hypothesis suggests an association between inflammatory diseases of the upper and lower respiratory tract, which are based on T2 inflammation. Mechanisms of inflammation in T2 diseases are mediated by interleukin 4, 5, and 13, which cause similar changes in tissues of the upper and lower respiratory tract. Interleukin 4 causes switching of B lymphocytes to the synthesis of allergen-specific IgE. Interleukin 13 also promotes B lymphocyte switching to IgE synthesis and causes excess mucus production, goblet cells hyperplasia, and smooth muscle hyperreactivity. Interleukin 5 induces differentiation and maintains the survival of eosinophils in the bone marrow. All three of these cytokines promote the migration of eosinophils into tissues. Inflammatory endotypes underlie asthma phenotypes or its clinical characteristics. Interleukin 4, 5, and 13 can be produced by either T helpers of the second type or innate lymphoid cells of the second type, accordingly clinically manifested as allergic or non-allergic eosinophilic asthma. With the predominance of eosinophilia associated with innate lymphoid cells of the second type, the patient develops non-allergic eosinophilic asthma with late onset, frequent exacerbations, fixed obstruction, blood and sputum eosinophilia, concomitant nasal polyps. And in this case, anti-interleukin 5 drugs, mepolizumab, rislizumab, benralizumab, can be used, as well as anti-interleukin 13 drug, dupilumab. With the predominant Th2 response, we see signs of allergic asthma in the patient, family history of allergies, early onset, positive results of allergy testing. In this case, IgE antibodies can be affected by omalizumab. If therapy is ineffective or it's impossible to calculate the dose of omalizumab, or there is a combination of severe asthma with atopic dermatitis, it's possible to prescribe the anti-interleukin 4 and 13 drug dupilumab. Thus, an anti-interleukin 4 and 13 strategy would be effective in both T2 inflammation phenotypes. Our study was conducted on the basis of a regional register. Therefore, a few words about the territory on which the register operates. This is a Sverdlovsk region of Russia. Its population is about 4,200,000 people. As for October 2022, there are 138 patients with severe asthma in the register. Almost 45% of patients have non-allergic asthma. Most of these patients receive anti-interleukin 5 drugs. 41% are patients with allergic asthma, and most of these patients receive omalizumab. Dupilumab is prescribed to patients of all phenotypes. We have 37 patients on dupilumab in our register. What are these patients receiving dupilumab dupilumab. 81% are women. The average age is 52 years. The predominant phenotype is non-allergic eosinophilic asthma. The predominant phenotype allergic eosinophilic asthma. 89% of patients have chronic inflammatory nasal diseases. 16% have atopic dermatitis. Dupilumab was prescribed to 25 patients initially, and 12 patients were switched from other molecules due to inefficiency. 89% of patients had chronic inflammatory nasal diseases. Among them are 27% chronic rhinosinusitis with nasal polyps, 24% combination of allergic rhinitis and chronic rhinosinusitis with nasal polyps, almost 19% each of allergic rhinitis and chronic rhinosinusitis without nasal polyps, and 4 patients had no nasal diseases. What can be said about the subgroups of patients with nasal diseases? The youngest patients are the patients with allergic rhinitis. The older patient is patients with chronic rhinosinusitis without polyps. Also, these patients were diagnosed with asthma later than the others, and the same group has a high body mass index. Intolerance to non-steroid anti-inflammatory drugs was more common in patients with chronic rhinosinusitis with and without polyps. Atopic dermatitis was more common in the group of patients with allergic rhinitis, and this explains the high level of total IgE in this subgroup. Positive Fadiatop was in subgroups with allergic rhinitis. So, to evaluate the efficacy of dupilumab therapy, we conducted an open, non-interventional, prospective, non-randomized study without a control group. A before-after analysis was performed. Patients entered the register by referral from doctors of the whole region to the chief specialist allergist immunologist. At the inclusion stage, blood eosinophils, spirometry, total IgE, Fadiatop, skin test and specific IgE, therapy volume, control level, emergency calls, exacerbations, hospitalizations are evaluated. Questionnaires are filled. Taking into account the phenotype, the patient is prescribed one biologicals or another. Checkpoints for monitoring patients on therapy at the 4th and the 12th month of therapy and every 6 months thereafter. Of the 37 patients receiving dupilumab, 37 completed the inclusion phase, 34 completed 4 months of therapy, and 20 patients received dupilumab for 12 months or more at the time of data analysis. The primary endpoint in our study was asthma control level by ACT and the reduction in the rate of patients with uncontrolled asthma. In addition, we evaluated number of asthma exacerbations, emergency call, hospitalizations, dosage regimen of systemic glucocorticosteroids, need for bronchodilators, quality of life by AQLQ, sinonasal symptoms by SNOT-22, and visual analog scale. We also conducted a subgroup analysis. We looked at how the presence of chronic inflammatory nasal diseases affects the efficacy of asthma therapy, and how the initial level of eosinophils affects the efficacy of therapy. We received an increase in ACT scores already at the 4th month of therapy, with the trend continuing to the 12th month. Accordingly, the rate of patients with uncontrolled asthma decreased from 100% at baseline to 47% in the 4th month and 42% in the 12th month of therapy. By the 12th month, of therapy, 4 patients had completely controlled asthma. With an increase in the rate of patients with controlled asthma, the need for SABA decreased from 17.5 doses per week before the start of dupilumab therapy to 1 dose per week after 12 months of treatment. Prior to the start of biological therapy, 68.5% of patients received systemic glucocorticosteroids. By month 4 of dupilumab treatment, the number of patients requiring systemic glucocorticosteroids decreased to 10.5% and persisted until month 12 of therapy. Against the background of biological therapy, there was a statistically significant decrease in the number of exacerbations from 2.19 at baseline to 0.22 per patient per year after 12 months of therapy, and a decrease in the number of hospitalizations from 1 to 0.17 per patient per year. The number of emergency calls for asthma exacerbation decreased, but the dynamics was statistically insignificant. During the year of therapy, there was a statistically significant increase in forced expiratory volume for the first second, from 55.4% initially to 81.5% in 12 months of therapy. During therapy with dupilumab, an increase in the number of eosinophils in peripheral blood was observed from 460 cells per microliter initially to 522 cells at the 12th month of therapy. Transient eosinophilia is associated with the mechanisms of dupilumab action and did not affect the therapy efficacy. Assessment of the state of nasal pathology in dynamics was carried out using the SNOT-22 questionnaire and visual analog scale. Before-after analysis revealed a significant decrease in SNOT-22 and VAS scores, indicating an improvement in nasal breathing function. Next, we compare the dynamics of average score in ACT test in subgroups with different nasal diseases. Before the start of biological therapy, there were no significant differences. By the 4th month of dupilumab therapy, a statistically significant difference between subgroups appeared. The subgroups of patients with chronic rhinosinusitis with nasal polyps and the combination of allergic rhinitis and chronic rhinosinusitis with nasal polyps had significantly better control of asthma compared to patients with concomitant chronic rhinosinusitis without polyps. By the 12th month of treatment, the trend continued, but due to the small number of patients in the subgroups, it's impossible to assess statistical significance. Also, we evaluated therapy efficacy depending on the initial level of blood eosinophils. 2 subgroups were identified with eosinophils less than 300 cells per microliter and 300 cells and more. Initially, these subgroups for ACT and FEV1 did not differ from each other. There was an increase in ACT to 18 and FEV1 to 64.5% in subgroup with eosinophils less than 300 cells per microliter after 12 months of therapy. But these changes were not statistically significant compared to baseline levels. In subgroup with significant increases in ACT up to 22 and FEV1 up to 86%. So, conclusion. Phenotyping of severe asthma allows us to choose an effective biological therapy. Dupilumab therapy is accompanied by an improvement in exacerbations and hospitalization, an improvement in respiratory function, and it allows to reduce and cancel systemic glucocorticosteroids in basic therapy in patients with severe asthma, and to reduce sinonasal symptoms in patients with concomitant chronic inflammatory nasal diseases. The efficacy of asthma therapy was significantly higher in patients with concomitant chronic rhinosinusitis with nasal polyps and combination of allergic rhinitis and chronic rhinosinusitis with nasal polyps compared to patients with chronic rhinosinusitis without nasal polyps. And efficacy was significantly higher in patients with baseline peripheral blood eosinophils 300 cells per microliter and more, compared to patients with baseline peripheral blood eosinophils less than 300 cells. A significant positive clinical and functional effect occurs after 4 months of dupilumab therapy. Thus, anti-interleukin 4 and 13 therapy, which most effectively influences T2 inflammation, is the key to successful approach to the management of patients with severe asthma and chronic inflammatory nasal diseases. Thank you for your attention.